Hello, my name is Dr. Frank Guido-Sanz, and I will be presenting the Mesenteric Ischemia lecture as part of the Gastrointestinal Healthcare Problems Lecture Compendium presented by Dr. Christopher Blackwell, Associate Professor and Program Director of the Adult Gerontology Acute Care Nurse Practitioner Program. Mesenteric Ischemia. Before we get into the particulars of etiology, definition, and clinical manifestation of this entity, we need to review a little bit our anatomy. Typically, the mesentery is irrigated or vascularized by two major arterial systems, the celiac artery and also the mesenteric artery. The celiac artery supplies the foregut, hepatobiliary system, and the spleen. The superior mesenteric artery, so the mesenteric system is divided in superior and inferior. The superior mesenteric artery supplies the midgut, including small intestine and proximal midcolon, and the inferior mesenteric artery supplies the hindgut, or the distal colon and rectum. But multiple anatomic variations have been observed. Venous drainage is through the superior mesenteric vein, which combines the splenic vein to form the portal vein. So in this slide, we see a very, very good view of the anterior or representation of the anterior view of the celiac trunk and its branches. And as we can see, all the arteries that are irrigating those particular organs. We have the right gastroepiploic artery, we have the right gastric artery, the proper hepatic artery, the common hepatic artery, the gastroduodenal artery, the superior pancreatico-duodenal artery. The duodenum of the small intestine, as you can see, is also irrigated by the superior mesenteric. We have how the esophageal branch of the left gastric and the short gastrics contribute to irrigation of like vital organs, and the left gastroepiploic artery. This slide shows an anterior view of the superior mesenteric artery and its branches, and we can see the mid-colic artery, the inferior pancreatico-duodenal artery, the right colic, the ileocolic, and the inferior mesenteric artery. We also see the superior mesenteric artery on the left side irrigating jejunum, jejunals, the ileals, arteries, and we'll see there that little loop there of the ileals, how they also take care of they're part of the superior mesenteric artery branches, how it vascularize the ileum of the small intestine. And then this one shows the anterior view of the inferior mesenteric artery and its branches. We see the left colic, we see the sigmoids, the superior rectal, and how these arteries, basically vascularize the whole portion, the whole left portion of a little bit of the transverse and descending colon, or descending large intestine, and some portions of the sigmoid, and through the superior rectal, the sigmoid and the rectum of the large intestine. So, how we define mesenteric ischemia? Well, mesenteric ischemia usually results from when the bloodstream, really, in an umbrella term, the bloodstream fails to carry sufficient amounts of oxygen and nutrients to meet the intestinal needs. And this ischemia may be related to either an occlusion by an embolus or a thrombus, or absolutely not related to physical occlusion. So we usually divide the etiology of mesenteric ischemia into acute arterial occlusion, um, and also mesenteric venous thrombosis, because it could be also originated by venous thrombosis, or non-occlusive mesenteric vascular disease, or what is also known as non-occlusive mesenteric ischemia, which, by the way, is more common than the acute arterial occlusion and mesenteric venous thrombosis, and is usually related to low flow conditions and mesenteric vasoconstrictive states. In this non-occlusive mesenteric ischemia, the flow is very slowed down, not by an obstructive mechanism, but by either arterial spasm or a physiological response to shock, or to sepsis, and even to cardiac dysfunction like CHF, aortic stenosis, or maybe also related to the use of vasoconstrictive drugs. So, in more specific terms, is usually defined as inadequate blood flow again to this intestine, and we, for the purpose of this lecture, we're characterizing this mesenteric ischemia into acute and chronic. Um, Different for MI versus CMI are the clinical presentation, diagnostic concerns, and treatment. So let's review a little bit of the pathophysiology. In essence, like I said, is the inability to achieve postprandial hyperemic intestinal blood flow. Normally, hyperemic pancreas and small bowel with peak of 30 to 60 minutes after eating. Significant arterial occlusive disease will result in inability to increase blood flow, will result in ischemic pain similar to angina pectoris, and what is it called? The mesenteric angina. And it's mostly due to arteriosclerosis. As you can see here, there's some collateral pathways for mesenteric vessels, and the importance of these collateral network is because usually the normal visceral circulation is fairly redundant. The celiac axis and superior mesenteric arteries communicate through the superior and inferior pancreatical duodenal arteries. The superior and inferior mesenteric arteries communicate through the meandering artery and the marginal artery of Drummond, with the meandering artery serving as the dominant collateral. The inferior mesenteric artery communicates with the internal iliac artery through the hemorrhoidal vessel. And it's sort of, this shows how, our body tries to compensate, because since the GI system is so large and so incredibly important, has found ways to, in light of the obliteration of the blood supply to any of these particular organs, and or the system in its totality, this collateral circulation helps to preserve the functional and physiological capabilities of the parts or organs that are involved in or present as acute thrombosis um, or occlusion or venous emboli. So, what are the symptoms? They usually occur if 2 or 3 visceral vessels are significantly diseased. Remember that rich collateral network is precisely in place to prevent the occurrence of this sometimes catastrophic mesenteric ischemia. It may occur with isolated disease, um, in the absence of adequate collaterals in the superior mesenteric artery. So, what is the clinical presentation? Well, it's usually you'll see it very common in cachectic elderly women with a strong smoking history. Here we go again with a cigarette, right? It's more common in women in a 3-to-1 ratio. Usually the mean age is 66 plus minus 11. So you can see the range, from 55 to 77. Abdominal pain is a presenting symptom, very, very pathognomonic, initially postprandial, and with time it can progress to persistent. Because of pain, these patients have a fear of food and they basically avoid eating. So it sort of like fits the habitus, right? Someone very cachectic with a net weight loss of 20 to 30 pounds. There is usually evidence of systemic vascular disease, which is also can be attributed to the smoking. No, so how we come to diagnosis? Well, for this chronic mesenteric ischemia, the differential diagnosis of abdominal pain plus weight loss is extensive. So you have to exclude any GI malignancy first. So initially, how we go about diagnostic procedures, an esophagogastroduodenoscopy, an endoscopic procedure is warranted. Colonoscopy, either by abdominal ultrasound also, or more conclusive is an abdominal pelvic CT. In terms of diagnosis times for being chronic mesenteric ischemic or CMI, the time exceeds 1 year. And is supported by high-grade stenosis in multiple mesenteric vessels. Angiography is the current gold standard for diagnosis of CMI. Angiography is the current gold standard for the diagnosis of CMI. The physical exam, again, is non-specific. You may hear abdominal bruit in 50% of the cases, but again, it's a 50-50 possibility. Labs, CTA, MRA, will identify stenosis reasonably and determine the best route to be reached angiographically. So obviously for intervention purposes. And the treatment, taking consideration the natural history and whether it's death or bowel infarction. These patients are usually treated on TPN or they need surgical revascularization. And this revascularization involves angioplasty with or without stenting or an open surgical approach, which is very, very risky. Here you will see in these arteriograms, it says this is a CT with arteriograms of CMI. They show in a patient with chronic mesenteric ischemia an occluded celiac axis and superior mesenteric artery. Where you see A on your left side, the origin of the superior mesenteric artery is shown with an arrow. And there is no contrast within the lumen of the vessel in this cross section, as you can see. In the B view, the superior mesenteric artery is shown with the arrow in this cross section that is like 10 millimeters caudal to the first image. The artery is patent at this level as reflected by the contrast in the lumen. So interesting, this CT study. If we further evaluate this patient with a lateral aortogram, you will see in a patient with chronic mesenteric ischemia, that in the left side of your slide, in slide A, there is a moderate stenosis in the proximal superior mesenteric artery as shown with the arrow. In B, there's no residual stenosis in the superior mesenteric artery after a placement of intraluminal stent. The quality of these pictures are not very good, but sometimes, and also depends on the type of stent that is deployed, you will see. So this is a pre and post intervention views or aortogram in a CMI patient. Another surgical intervention is the completed antegrade bypass from the supraceliac aorta to both the celiac axis and SMA. I have to say that this is a very highly technical surgical topic where usually interventional radiology and vascular surgeons are involved. And our role as nurse practitioners is basically to be able to identify the signs and symptoms, think about the possibility of the condition, and refer these patients to the appropriate providers. Here, it shows a complete antegrade bypass from the superior supraceliac aorta to both the celiac of the celiac axis, and the superior mesenteric artery is shown here. This is sort of like um, sketch that you will see very common in vascular surgical notes to explain visually what kind of procedure was done on the patient. So again, this is a bypass from the supraceliac aorta to both the celiac axis and the superior mesenteric artery. In this diagram, we see the retrograde aorta superior mesenteric artery bypass. So one was the antegrade, and this following one is the retrograde. Here you see the completed retrograde bypass from the terminal aorta and proximal right common iliac artery to the superior mesenteric artery bypass. Again, this is something that you have to become familiar a little bit with all these diagrams, because you will see this very often in the surgical notes. So you will be able to sort of like graphically and visually understand in a nutshell what kind of procedure the patient went under. So what happened after surgery? Well, um, this is usually these patients are usually complicated with multi-organ dysfunction syndrome. Why? Because of the extent sometimes of this impairment of vascularization, which turns into prolonged ICU and prolonged hospital stay, and is the leading cause of death in the post-op period. Visceral ischemia plus reperfusion phenomenon is a complex response um, to by interrelated inflammatory mediators. So imagine, this is a patient that have been subject to a large area of ischemia, translocation of bacteria, the possibility of septic shower during either the non-surgical or surgical approach. In this case, it's surgical. So a very vulnerable time for these patients. CMA, this is ominous, putting, some stones in this slide. CMA revascularization outcomes, as you can see, it does have a perioperative mortality less than 15%, and with a good 5-year survival after either type of revascularization is 75. So I have no idea why Dr. Blackwell chose tombstones for this because the mortality is not that high. Although from the revascularization itself, I think the problem comes with the potential complication of this patient. But if they can bypass that postoperative time without any of the complications, there is a good chance of 5-year survival, over 75%. So, in terms of CMI, what are some pearls that we're providing here for you? The underlying pathophysiology, again, of CMI is the inability to achieve postprandial hyperemic intestinal blood flow. Symptoms of mesenteric ischemia usually do not occur, usually unless 2 of 3 visceral vessels are significantly diseased because of the collateral network. Patients presenting with abdominal pain and weight loss should initially undergo an evaluation to rule out any gastrointestinal malignancy. CT arteriography has replaced catheter-based contrast arteriography as a diagnostic study of choice for patients with CMI. Endovascular treatment has emerged also as the initial revascularization option for most patients with CMI, but should be reviewed as an alternative to open surgical revascularization. The immediate postoperative care for patients undergoing revascularization for CMI is frequently complicated by the development of multiple organ dysfunction, and the optimal management strategy for patients in the early post-op period after mesenteric revascularization is to support the individual organ systems until the dysfunctions resolves. And now let's talk about acute mesenteric injuries. What are the causes? Well, they're usually related to emboli, in situ thrombosis, and in situ thrombosis, which are the most common causes. It's usually attributed 50% of the cases to emboli, 25% to thrombosis, and 20% of non-occlusive mesenteric ischemia. Balance equals aortic dissection. So I have something to add here. I basically dispute a little bit um, the the data in this, and it's something that we can talk about with Dr. Blackwell, because it says that the most common causes for mesenteric emboli and in situ thrombosis, they attribute only 20% to non-occlusive mesenteric ischemia, but the most update consensus is that non-occlusive mesenteric vascular disease or mesenteric ischemia is more common than arterial occlusion and venous thrombosis. So just hold on to that thought. Acute mesenteric ischemia represents like 0.1% of all hospital admissions, and you have 4 clinical entities responsible for that. Mesenteric venous thrombosis, or MVT, acute mesenteric arterial thrombosis, or AMAT, acute mesenteric arterial embolus, MA, and non-occlusive mesenteric ischemia, or NOMI, NOMI. Final common pathway is particularly significant in AMI is your bowel ischemia leading to bowel wall gangrene. As you can see, this wet gangrene of the intestine pictured. I have seen only twice in my whole career, and it's so impressive. And believe me, that pictured is absolutely very, very accurate to what you will see in a patient with bowel wall gangrene. It's a huge mortality associated with that, 60 to 100%. And it's really, when you see a patient presenting like this, it's really a calamity. And if they survive the post-operative period, they are left with an enormous number of sequelae. So how all this starts, this pathophysiology of the acute mesenteric injury, it usually obviously starts with an impaired intestinal perfusion, compromising the mucosa, releasing that intracellular content, um, which in turn produces an influx of substances from the bowel of the lumen, including bacteria. So that's the translocation of the bacteria, activating the systemic inflammatory response system. So you will have, local and distant organ dysfunction, and finally, bowel infarction with perforation and peritonitis. In terms of the pathophysiology of the embolus, you have um, AFib, acute MI, ventricular aneurysm. You have also intracardiac thrombus and also an emboli in the SMA as possible causes. And let's review a case which is pretty interesting. A 76-year-old woman presents to the ER with intense abdominal pain. She describes the pain as a diffuse, severe, constant ache throughout her abdomen. The pain woke her from sleep several hours ago. She felt well when going to bed last night with no discomfort or other preceding symptoms. Today she feels nauseous and has had two liquid bowel movements that were dark brown in color. She has never had similar pain before. She denies having any fever, trauma, urinary symptoms, vaginal discharge, or bleeding. There has not been any chest pain, shortness of breath, or back pain. She has a medical history of atrial fibrillation, a myocardial infarction 2 years ago, Stu already, with two stents placed, hypertension, and chronic obstructive pulmonary disease, COPD. She admits to being a lifelong smoker and has smoked 1 to 2 packs daily for at least 50 years. She has a glass of sherry nightly, but she denies ever using drugs. She has no history of abdominal surgery. She is a widow homemaker who lives alone, but she has two daughters who live nearby. She has been prescribed multiple medications, including warfarin, atenolol, and ipratropium salbutamol inhaler, lisinopril, a multivitamin, and hydrochlorothiazide. She admits to frequently missing doses of her medications and recently ran out of warfarin. She has no known drug allergies. So, physical examination of these patients. The patient appears to be in intense pain with an oral temperature of 99.4 Fahrenheit, an irregular heart rhythm with a heart rate of 118. Her blood pressure is 101/68, and her respiratory rate is 22 breaths per minute. Her pulse oximetry is reading 93% on room air. In general, she appears older than her stage age, appropriately alert and oriented, with slight expiratory wheezing throughout bilateral lung fields. No murmurs are appreciated on cardiac auscultation, and her abdomen has only mild tenderness to palpitation diffusely. No peritoneal signs on examination, palpable masses or abnormal pulsations are noted. Rectal examination reveals dark brown stool that is negative for occult blood. She has no costovertebral angle tenderness. Her extremities are warm with 1 plus bilateral dorsalis pedis pulses. Let me go back really quick to that rectal examination. Guys, anytime that you have a patient complaining of abdominal pain that it seems to be very sick, very insidious presentation, is accompanied by nausea, vomiting, or diarrhea, even worse with blood in stools. um, Rectal examination is a must. That is sort of like standard of care, and you need to do it. It's ominous, it's horrible for the patient, especially for male patients, but it has to be done. You cannot be prude because you can miss a really you know, bad condition, and you're only putting your license to um, peril. So really, rectal examination in cases that are presenting where the chief complaint is totally related and exclusive of the abdominal system, the GI system, you should always do a rectal exam. Unless there's obvious contraindications like bleeding, a prolapse rectum, or a bleeding internal hemorrhoid, or something that you might disrupt more than than benefiting the patient from the um, examination. The patient is placed on cardiac monitor, two large bore peripheral IVs are placed, and fluid resuscitation with normal saline is started. The patient is given two 8 mg doses of morphine with some pain improvement. She's given 4 mg of ondansetron for her nausea. A bedside lab test shows a hemoglobin level of 12.1. A bedside ultrasound shows no free fluid in the abdomen. An electrocardiogram demonstrates rapid atrial fibrillation without an acute injury pattern. A stat right chest x-ray is obtained and demonstrated hyperinflated lung fields but no free air, which is good, under the diaphragm or other acute abnormalities. Lab studies including electrolytes, hepatic panel, lipase, cardiac enzymes, and a complete blood count are performed and found to be without significant abnormalities. Her international normalized ratio, INR, is subtherapeutical at 1.4. An abdominal computed tomography, CT, angiography scan is ordered, CT angio, CTA angio. So what do we have here? We see here the superior mesenteric artery shown by the small open arrow. The right hepatic artery, the small solid arrow there, originates from the SMA. The right hepatic artery courses through the portacaval space and between the portal vein, which is the large open arrow, and the inferior vena cava, which is the solid arrow. So this is showing us the vessel. What else we can see here? We see just the liver, and we see right kidney there. Pneumatosis intestinalis. The CT shows in a further caudal cut um, with SM positive with SMV air. The pneumatosis intestinalis, which is defined as gas in the bowel wall, is often first identified on abdominal radiograph or computer tomography scans. It is a radiographic finding and not a diagnosis, as the etiology can vary from benign conditions to fulminant gastrointestinal disease. Pneumatosis intestinalis is considered an ominous finding in ischemia, especially in association with post-mesenteric venous gas. The disease is seen in other conditions, including chronic obstructive pulmonary disease and COPD, connective tissue disorders, infectious enteritis, leukemia, syndrome, acquired immunodeficiency syndrome, and found also in transplanted organ transplanted patient, and steroid use or chemotherapy. So this is another view on the plane of sagittal plane of the CT scan, and we continue examining the radiographic evidence showing here that we have a parenteric fat stranding, ascites, which is depicted by all this. Let me see here, the fluid in the abdominal cavity and the wall thickening of the bowel. And further down, we also can see some portal venous air, which is also a sign, CT angio sign associated with the mesenteric ischemia. So CT angiography show a supplanted traditional angiography. Instead of like plain CT, we're using angiography. And this increased ease and minimally invasive approach. And the sensitivity for acute mesenteric ischemic is 96 to 100%. Although the specificity is not that high, it is pretty good. It's 89 to 94%. So what this tells us that this is an emergency surgery issue. We have to immediately consult vascular surgery for the um, basically repaired and intervention to prevent further deterioration of this patient and further extension of the ischemia in the mesentery. The supportive care for this particular presentation is providing supplemental oxygen to the patient, obviously airway intervention, fluid resuscitation. These are patients that require an enormous amount of crystalloids, and obviously they run into the risk for pulmonary edema, so usually the patient will remain intubated for quite some time after surgery. Obviously, we need to treat the underlying conditions, administer broad spectrum antibiotics, being very liberal with pain control. And your early consults will be, following up with that vascular surgeon. Obviously, initially you contacted them and for the intervention. And sometimes interventional radiologists are consult simultaneously because they can go in along with a surgical team, and at that point they can make a decision whether they can just treat this through an interventional radiology procedure, or indeed if the patient needs invasive vascular surgery. In terms of treatment options, again, it depends on the etiology of the ischemia. For non-occlusive mesenteric ischemia, we have the infusion of papaverine. Papaverine is a smooth muscle relaxant that has been available for over 60 years, and it has been marketed initially for the relief of cerebral and peripheral ischemia conditions secondary to arterial spasm. So these conditions may include, acute myocardial infarction, angina pectoris, peripheral and pulmonary embolism, peripheral vascular disease with a vasospastic element, or the certain cerebral angioplastic state. Also for visceral spasm causing urethral, biliary, and or gastrointestinal colic. Nevertheless, the FDA evaluated studies on papaverine and concluded that there was a lack of objective data to support the therapeutic use of papaverine. So it remains controversial. It remains available despite the committee's recommendation that it should be withdrawn from the market. And to be honest with you, I have never seen a patient treated with this infusion. They also go for surgical embolectomy. They can use other transarterial infusion of vasodilators, but not really. They may use intraarterial thrombolysis, bypass grafting, stenting, anticoagulation, anything that will medically optimize the flow. And this picture really shows, all the alternatives to surgery and endovascular therapy. You have your percutaneous transluminal balloon angioplasty and stenting, your transanterior thrombolysis, and your transanterior infusion or vasodilator in the case of NOMI. So, summary and pearls for acute mesenteric ischemia. The impaired intestinal perfusion associated with acute mesenteric ischemia leads to mucosal compromise that can lead to the activation of the systemic inflammatory and bowel infarction with perforation. The immediate clinical concerns for patients with AMI are to reverse the underlying clinical condition and always prevent bowel infarction. The cause of AMI could be an embolus, an in situ thrombosis, NOMI, mesenteric venous thrombosis, or dissection, and can usually be determined from the history and the clinical setting. The emboli responsible for AMI usually lodge in the superior mesenteric artery and originates from the heart as a result of atrial fibrillation. So, AFib patients very, very prone to this acute mesenteric ischemia, and also acute myocardial infarction or a ventricular aneurysm. In patients with in situ thrombosis, the presentation of acute mesenteric ischemia is superimposed on the symptoms of chronic mesenteric ischemia in more than 50% of the patients. So that's something to also keeping in consideration. Like you saw the case, she was a smoker for so many years and fit the profile of CMI, but now she was like presenting with an acute, you may say, exacerbation of maybe the underlying symptoms. And obviously, a different story now, which is acute that required, rather than medical intervention, surgical intervention. And that's it. This concludes this lecture. A little bit more. I want to go back really quick and give you some other pearls on the acute mesenteric ischemia. NOMI again represent an abnormal or paradoxical mesenteric vasoconstriction, which is characterized by the loss of autoregulation, and that's why dilators are used. Mesenteric venous thrombosis is associated with a high incidence of hypercoagulable states and merits long term of anticoagulation, like we saw in the case presented. She was on warfarin. CT arteriography with 1 to 2 millimeter cuts has emerged also as diagnostic study of choice for patients with AMI. So CT angio is a study of choice for this acute mesenteric ischemia. Patients with AMI from an embolus or in situ thrombosis require emergent operative treatment. Never fail to consult surgical vascular surgery immediately. And your operative treatment for patients with NOMI and mesenteric venous thrombosis is reserved for cases in which bowel infarction is suspected. Okay? And this concludes our presentation of mesenteric ischemia, lectured as part of the Gastrointestinal Healthcare Problems Lecture Compendium by Dr. Christopher Blackwell, Associate Professor and Program Director of the Adult Gerontology Acute Care Nurse Practitioner Program. Thank you very much for your attention.